Welcome, everybody. I'm so thrilled to see so many people here for you to listen to what really promises to be a very exciting presentation on long COVID. And that's a topic that's puzzled and intrigued so many of us for close to 3 years now. Before we go with our speaker, though, I'd like to begin by describing a little bit about our group and what we do. First of all, I am Dr. Maureen O'Reilly Landry. I'm founder and I co-chair with Dr. Patricia O'Gorman, who you'll be hearing from in a moment. And we co-chair the Hospital Health and Addiction Workers, Patients and Families Working Group. We're members of the COVID-19 Psychology Task Force, which was established by 14 divisions of the American Psychological Association. We're located within the Division of Psychological Trauma of the APA. Our group consists of psychologists and other mental health professionals who came together in March 2020 with a mission. We were going to address the psychological trauma we were all predicting would ensue. Sadly, we weren't wrong, and we've been working since then to address that trauma. Next slide, please. So our initial mission was to collect resources that were informational, educational, and for training to help people to cope in one way or the other with whatever aspect of the stress and trauma they might be encountering during the pandemic. So we developed a website, resiliencincovid.us, which is where these resources are housed. And then we also developed a blog. It's through Psychology Today, and Psychological Trauma, Coping and Resilience, COVID-19 and Pandemics. That consists of articles that primarily written by the various very talented experts that we have within our group to address a whole range of issues of the stress of the pandemic. And so we have two subgroups now. One is the long COVID group, which is the one that is sponsoring the talk today. And that came from one of the speakers that we had here. And then we have a second subgroup. This is in addition to the other things that I was describing. A second subgroup to address issues in the ICU and emergency critical care. And our very first talk was, and it was before we knew we were going to have a series, Dr. Alla Landa, who might be here today, right now. She is assistant professor of clinical psychology at Columbia University Medical Center, and she does a lot of research on the mind-body connection. And so I knew about her. I know her, and thought it would be fascinating just to have a discussion about possibilities for, the title of it was, Can What We Already Know About Mind-Body Disorders Help Us to Understand Long COVID? Now, keep in mind, this was over a year ago, October 2021. And I'd just like to introduce briefly our long COVID group. And that is co-chaired by Janet Plotkin-Bornstein, Betsy Gard, and June Fader. And the other list of people here are, those of us who contribute in one way or the other. But the ones who are really spearheading this are those first three. Just to show you the range of talks that we've had. We had one in September, how celebrating recovery from addiction may help us to understand how to frame recovery from long COVID. And then we had another one on a completely different topic. One of the things that we were dealing with was vaccine hesitancy back a year ago as well. And so we invited a professor from Penn State who had written a book in 2019 called Anti-Vax, Reframing the Vaccination Controversy. And so she had been researching that topic for a very long time. So you can see we've had some very outstanding people coming to speak, and including today. And just a little bit about the range, again, of the type of topics that we've covered in our blog. We had one addressing child abuse during the pandemic, and based on Dr. Rodriguez's own research about what was going on in homes during the pandemic. And then our own Dr. Robert Gordon, who you will hear from in just a moment, writing about, something that much more mundane that we all experienced. Why am I so tired? And a description of why physiologically and psychologically that was happening. So now I'd like to introduce my co-chair, Dr. Patricia O'Gorman, and she is then going to introduce our group members.
It's wonderful to have so many of you here. And as we know, decisions get made in any group by those who show up. And we have been, Maureen and I, privileged to have a core group of people who have been meeting weekly with us, believe it or not, weekly, since March of 2020. And we have many of those members attending today. And I just want to give a shout out. Jen Chapp, our incredible IT wizard and advocate, who has helped us develop. By the way, everyone who has joined has helped develop and move us in a direction, and you are all invited to join. Matt Freed, who is just a dear, an incredible psychologist and author, who is from a rural part of New York State, as I am. I'm speaking to you from the Adirondacks, where it's snowing. Our dear Betsy Gard, who is from Georgia. Robert Gordon, who I will loop back to because he will be introducing our speaker. He's an incredible writer and advocate for us as well. Maureen, who you've met. Janet, who co-chairs our long COVID group, is with us, and I also have a personal nomiker for her, which is our resource detective. She has found so many resources that we have been putting up on our blog. Dr. Sally Riggs, who also will be presenting, who is a leader in the long COVID area. Rita Rivera, who comes to us from her doctoral internship at Duke and has been key in helping us set up the blogs. Lisa Rosenzweig and our Patricia Vilenchenko Carrillo from Madrid, who is basically almost every week attending our groups, and our own Ruth Jaffe from Connecticut. So I'd like to turn it over to Bob, who will be introducing our speaker.
I'm thrilled to introduce Dr. Lauren Oberlin. She's the assistant professor of psychology in psychiatry at the Department of Psychiatry at Weill Cornell Medical Center. And she's the assistant attending psychologist at New York Press. She specializes in the neuropsychological assessment and therapeutic treatment of middle-aged and older adults. She obtained her doctoral degree in clinical psychology and biological and health psychology from the University of Pittsburgh. And she completed her clinical internship in adult psychology and neuropsychology at NYU Langone Health. She received postdoctoral training at Weill Cornell Institute of Geriatric Psychiatry. Her research interests include identifying and refining novel treatments for mood disorders in aging and using brain imaging techniques to evaluate the mechanisms underlying new and promising interventions. She's an exceptional researcher, neuropsychologist, and clinical psychologist. So I'm thrilled to introduce her, and she's going to be presenting on the cognitive and emotional sequelae of long COVID, current trends, and emerging treatments. So I'll turn it over to Lauren.
All right. Thank you very much, Dr. Gordon, and for the introduction, for inviting me here today. I'm really thrilled to be here and be speaking with you all. So can everybody see this? And everyone hears me okay? Great. So as Dr. Gordon mentioned, I'll be talking about the cognitive and emotional sequelae of long COVID. I'm going to start by just discussing general features and incidence rates, some proposed mechanisms, and I'm going to focus primarily on potential treatment considerations, particularly within a therapeutic context. And I wanted to start by just giving a definition of long COVID, because I think we hear it used in a lot of different ways. And the sort of formal, I guess, clinical NIH defined term for this is post-acute sequelae of COVID-19, or PASC. And so the World Health Organization folks there brought in a panel of clinicians and researchers and people who have had COVID themselves to develop a consensus definition of PASC, or long COVID. And so it's defined as symptoms that onset usually within 3 months after COVID infection, that lasts for at least 2 months, and cannot be explained by an alternative diagnosis. Symptoms are new onset, and they might arise, and they may start during the infection, acute infection, and persist, or they might arise after someone initially recovers from acute infection. And these symptoms are considered to have some significant impact on daily functioning. And long COVID can be really variable in its expression and its impact, as many of us know. So the symptoms range and can include things like fatigue, shortness of breath, psychiatric symptoms, cognitive weaknesses, along with a whole host of other symptoms, including, so a lot of the other ones in that sort of long COVID category are included here on the left or on the right. And there's no minimum number of symptoms required for this diagnosis. So even just having one, depending on when it onset and its duration, can lead to kind of a formal diagnosis of PASC, or long COVID. And today I'll be focusing specifically on the psychiatric and cognitive symptoms. And so shown here, I just wanted to kind of give an overview of the prevalence of these. So shown here are data from a recent large population-based study of more than 11,000 people that examined the presence of various symptoms that were present 6 to 12 months post-infection. So that would certainly fall in that category of PASC, or long COVID. And the outer circles in gray represent individual symptoms, and the circle areas represent the proportion. So the size of circles are proportion, and the inner circles, the colored ones, reflect kind of clusters of symptoms. So as you can see on the right, fatigue is the most prevalent symptom, occurring in about 37% of the sample, followed by neurocognitive difficulties at 31%, and anxiety and depression impacting 1 in 5, or about 20%. Sleep difficulties are also common and impact about 1 in 5 individuals. And the rates can vary a little bit depending on when the measures were obtained, the population, the region. So ranges of neurocognitive difficulties in the literature have typically been between 15% prevalence to about 30% prevalence, whereas mood symptoms are pretty consistent at about 20% in adults post-COVID. And what I'll also mention is that it's more common for these symptoms to onset sooner after infection, within the first couple of months, especially with regard to mood symptoms. So after the first 2 to 3 months post-infection, the risk of psychiatric disorders specifically returns to kind of pre-morbid levels. So it's similar to that of the general population. And in terms of the specifics of the psychiatric profile, what studies have observed are higher rates of anxiety and depression. And those are what are most often kind of assessed in the literature, because the GAD-7 and the PHQ-9 are so easy to administer. But there are also elevated rates of post-traumatic stress disorder and psychosis. And these latter two, the elevation rates is fairly specific to people who have been hospitalized with severe infection. And in the case of PTSD, that the severity of symptoms tend to reduce over time. And the psychosis is most often in the context, psychosis symptoms in the context of delirium that present during hospitalization. And today I'll be focusing primarily on treatment considerations for individuals with long COVID that are experiencing anxiety and depression. And in terms of cognitive difficulties, so brain fog is a term that we hear a lot. It's often used to describe the experience of post-COVID neurocognitive challenges. So here's just some quotes from people who have experienced it themselves. And I think that they really encompass what it's like for people going through this. So I can't cope with multiple inputs. Like if I'm trying to reply to a message on my phone, oops. Sorry, I have to move this. And one of my boys starts speaking to me or there's something else happening, it just fries my brain. I can't keep multiple plates spinning. I'm fearful for the future. I'm kind of a loss of identity. I don't know who this person is. And so I think the term brain fog generally sort of encompasses this experience of feeling mentally fatigued, feeling confused, overwhelmed. And it's a great catch-all term. The only downside is that it's fairly vague and non-specific. So I think in a clinical context, the nature of difficulties can vary so much. So it's helpful to sort of assess the specificity of each individual's cognitive deficit. So in terms of the profile, the data so far suggests that attention and executive function are the domains that are most prominently affected. But weaknesses in processing speed and memory are also observed. The effect sizes just aren't as big as those that are being observed in executive function attention. Anecdotally, though, what I've found is in our clinics, memory difficulties tend to be most commonly reported, though the source of the memory difficulties may be related to memory as well as attention and executive difficulties. So if we're not attending to something, it's harder to take in and encode that information. So we're unable to remember it later. And executive difficulties, sort of processing information, organizing it and retrieving it later on. So I think some of these cognitive difficulties can really manifest in day-to-day as memory issues for patients themselves, even though their origin may be more related to attention and executive deficits. And studies have examined the risk of persistent psychiatric and cognitive symptoms in COVID compared to risk with other respiratory infections, like the flu. And they found that both persistent mood symptoms, which are shown here on the left, and cognitive symptoms, which are shown here on the right, have greater rates among those who experience COVID relative to other respiratory illnesses. And that suggests that the origin of these symptoms may, at least in part, result from pathophysiologic effects of COVID infection and not just be a general consequence of a viral infection. And the risk of long COVID features is also greater among those with severe infection. So, for instance, patients that require ICU stays tend to demonstrate a greater breadth and severity of cognitive impairment and mood symptoms. So shown in the upper right corner is a dose-response relationship between cognitive symptom severity and a COVID symptom severity and executive dysfunction, with higher impairment seen among those who were admitted to the ICU. And this is similar for mood. So shown in the bottom right are data from a really large population-based study showing that greater severity is associated with increased risk. But what I also want to really emphasize, I think this is important for individuals who have had COVID and have had milder symptoms to know, is that even though the risk is even greater, maybe 3- or 5-fold with severe illness, there's also a significantly greater risk among those with mild symptoms or who are asymptomatic. So it's also really, these risks are elevated across the board, but also in a dose response fashion. And data suggests so far that cognitive difficulties resolve over time in the majority of individuals who have long COVID. Though they may extend for longer periods of time in a minority of patients. But so shown here are findings from a longitudinal study of 1,500 COVID survivors and 500 controls, and showing the incidence rates of cognitive difficulties at 6 months on the left, and in the same population at 12 months. And we can see that in the both in the non-severe and severe group, the incidence really goes down, though there are some people with persisting symptoms. And so this study only goes out a year. And I've worked with patients who have had cognitive symptoms. They had COVID in March 2020 and had persisting symptoms for 2 years. And then the symptoms eventually resolved. So I think perhaps the duration is really quite variable, and there's not enough longitudinal data to know exactly what it looks like yet. And right now, this is something that individuals have asked me about, is just this fear of, am I going to decline? Do I have an increased risk of dementia? And right now, there doesn't seem to be really strong, compelling evidence that that is the case, that having COVID or having post-COVID cognitive difficulties sort of undoubtedly significantly increases your risk of dementia. And I think that's something with more time, with more longitudinal studies, because we've only had about 2.5 years to look into this, that we'll be able to kind of say more definitively either way. And in terms of the pathophysiology, so what are the kind of the underlying mechanisms that may be underlying these prolonged changes or symptoms? So far, there's some animal models, there's autopsy studies, really strong kind of mechanistic work that has been looking to explore this. And so the proposed mechanisms so far include endothelial damage, microvascular injury, metabolic changes, immune system dysregulation, and stimulation of a hyperinflammatory state. Right now, there doesn't seem to be data to suggest that COVID can directly infect neurons in the brain, but it may be able to kind of invade the extracellular space. And what more studies suggest is that COVID may lead to changes in the brain and brain tissue, blood vessels through indirect effects on the CNS. So through things like altering these sort of systemic or peripheral impacts that lead to changes in blood-brain barrier permeability and make it easier for things in the peripheral nervous system to get into the brain. And some factors may be virus-specific pathophysiology, while other pathways may be just related to immune aberrations caused by acute infection. And that's something that I think the research is still trying to disentangle. And there's also neuroimaging studies. So one of which is shown here. This was done in the UK Biobank data set, which has like 40,000 participants. It's really huge, really robust data set. And they found COVID-related differences in gray matter volume and white matter microstructure, and identified specific pathways that may be impacted by COVID. But we don't yet understand the sort of persistence of these changes and how they may manifest clinically. So I'm now going to shift a little bit and talk about considerations for therapeutic treatment among individuals with long COVID. And so during the initial surge of the pandemic in New York back in March of 2020, clinicians in our psychiatry department collaborated with physicians in rehabilitation medicine and pulmonology and intensive care to develop several treatment programs for individuals with COVID. So this included a inpatient rehab. So these are people who were critically ill with COVID. Most were on ventilators, hospitalized in the ICU, high rates of comorbid complications. And that was when we initiated both individual and group therapy. The second program was an outpatient clinic for individuals with long COVID. So this involved some multidisciplinary medical care, along with individual and group psychotherapy. The third program is called COPE NYP. So this was a remotely delivered psychological intervention for sort of just stress, emotional experiences, just for frontline healthcare workers going through it all. And many themselves had COVID because they were often exposed. And this was specifically early on in the pandemic when we initiated these programs, and then they continued over time. And I'll say that all of these programs were provided at no cost and to the patients and the healthcare workers. So what was nice was that we had the opportunity to work primarily with individuals from underserved and disadvantaged communities. And then the fourth program is actually a clinical research trial. So it's a digital cognitive training trial for post-COVID cognitive difficulties. It's seeing if sort of a video game-like intervention. So it's fun and engaging, but targets certain cognitive processes impacted in COVID. And we're seeing if this affects cognitive outcomes in people with kind of persistent cognitive deficits. We just wrapped up enrollment last week. So we have all 110 folks, and we're now in the data analysis phase. And so based on these experiences, we developed a program of treatment to address anxiety and depression among people who've had COVID across kind of levels of severity and care settings. So it's really an integrative approach that draws from cognitive behavioral therapy, acceptance and commitment, mindfulness-based strategies, existential, and motivational interviewing. And we've sort of combined and adapted these techniques to meet the needs of individuals who have had COVID. And we also drew from sort of existing treatments that were developed for medically complex populations. So in particular, Ph.D, which is the personalized intervention for depressed patients with COPD, and ecosystem-focused therapy, which was developed for post-stroke depression. And based on that data, we kind of developed our initial treatment program, and that was really shifted and iteratively refined based on our experiences with individuals who have had COVID. So based on our work, we sort of continuously updated our model and have recently published several papers on this treatment protocol. We also were invited by Treatments That Work to write a manual about therapeutic treatment of individuals who have had COVID. We just finished our draft. It's now in the review phase. So that we're hoping should be out within the next 6 months to a year. And so there aren't a ton of other published studies on specifically therapeutic interventions developed for individuals who have had COVID, but there are a handful. And their strategies sort of overlap with some of our components, which is great because it suggests that this trend seems to be helpful for individuals who have had COVID and improving outcomes and well-being. And so we've done some preliminary work showing that this general treatment program improves both mood, so anxiety and depression are shown here on the left, and that engagement in the treatment is also related to improvements in kind of functionally meaningful domains. So improved mobility and improved just ability to participate in ADLs, activities of daily living. And so we were also really impacted by the qualitative work of individuals who have had COVID, discussing their experiences, their psychological experiences. And there were several trends in the literature that we also observed in our clinical work, like individuals facing fear, a lot of fear, denial about symptoms, the acute nature and the trajectory of their symptoms, stigma, kind of accepting adjustment to illness and acceptance of uncertainty, quarantine-related stressors, which is now, it was such an important component of our work early on, just because of public health measures, really kind of restricted what everyone could do. Now with the vaccines, things are a little bit safer. People can start to go back to the things they used to enjoy, but it is still a factor. And a hypervigilance of physical symptoms, a lot of ruminative anxiety, and something I'll talk more about as well is just resilience. So many of the individuals we've worked with have gone through tremendous medical complications and stressors and have been shown so much bravery and resilience and worked so hard in their own recovery. So I'm going to talk a lot about these features now that are a little bit more specific to individuals with long COVID. And so listed here are the sort of key ingredients and therapeutic considerations that we found really helpful when providing care to individuals with persistent symptoms of COVID. I'm going to go into more detail about a lot of these. And I think thematically, a lot of these key ingredients are consistent across a lot of different approaches, like psychoeducation. And so I'm going to specifically focus on how these are really applied to individuals experiencing symptoms of long COVID. And we found psychoeducation on COVID-related factors to be really, really helpful. So a few key pieces of information that we like to emphasize are that The World Health Organization, the medical community recognize symptoms of COVID can persist after acute infection. And that's so critical because individuals with long COVID often face stigma and feel as if they suffer with an invisible illness. They may feel, often we hear people feeling dismissed by friends, families, and in some cases rarer, but even medical providers, especially those with mild infections. And others may not recognize the distress that people are going through because many of the symptoms are sort of invisible in nature. They're not easily observable. And so emphasizing that really the medical community at large recognizes this is real helps to validate their experience. That COVID symptoms and the affected parts of the body are really variable and can be, I mean, COVID affects so many organs in the body that the clinical manifestation is just really heterogeneous. And that symptoms can onset during acute infection and persist. So when people are sick, they start having headaches, and then those headaches persist, or they present after initial recovery. I think the latter is confusing for people, and they really are like, what could possibly be going on here? But it's not uncommon for that to occur. And that symptoms, particularly during or immediately after the infectious period, may or may not persist. So there are some symptoms that may get better faster than others. And that these symptoms can wax and wane with good days and bad days. This is something it's just a trend that we've noticed, that individuals feel like it's sort of like Groundhog's Day. They never know what they're going to get. And that's kind of typical, and sort of reassuring that it's all right. You may have a couple of bad days, but that doesn't mean you're always only going to have those. And that we don't know yet what might cause these persistent symptoms. We can't say definitively, but there is data showing clear biological pathways. Again, sort of reaffirming that what you're experiencing is real and legitimate. And finally, that despite the uncertainty regarding the cause, the emotional experience and suffering following COVID are treatable. That their physical symptoms, by treating anxiety and depression, they may notice improvements in physical symptoms. They may not, they may or they may not, and it isn't a guarantee. We know it's likely because of this reciprocal relationship, but even if, regardless of improvement in physical symptoms, by alleviating anxiety and depression, it can help improve quality of life and well-being and give individuals better tools to manage COVID symptoms. And something that really struck us as we started to kind of make our clinics accessible to the community was that so many people that we saw had never been in therapy before, didn't have a history of mental illness or psychiatric care. And so it was, for some, the first time they were experiencing really intense, chronic, unpleasant emotions. And that was really destabilizing, which is another reason that psychoeducation is such a crucial piece. And with regards to COVID, and also with regards to just identifying and validating emotions. And we know that persistent physical and medical symptoms of COVID can exacerbate intense emotions. And so some common emotions experienced by individuals with long COVID include fear and anxiety, but during the acute illness, fear may have motivated the need for symptoms to be brought to medical attention. Fear, anxiety may have been really adaptive acutely, but after that infectious phase or in times of relatively low viral transmission, this fear may persist in a lot of individuals. And there's also sadness. Clients may feel sadness because of loss of mobility, loss of time due to illness or hospitalization, death of loved ones, changes in work and family roles, and guilt. So sometimes individuals may feel guilty that they should have somehow prevented themselves from becoming infected. Or one of our earlier patients, when she contracted COVID, she was placed on a ventilator for a month. And while she was on the ventilator, her son died of COVID. And that is just beyond devastating. And also that, some people experience survivor guilt. Why did I live through this and my husband or my loved one didn't? Or they may feel guilty about being able to function as they did prior to
Hello.
COVID. Mhm.
Yeah.
Sorry.
Yeah, I'm on the
Oh, okay. Sorry, I thought someone had a question. Or guilt on taking on kind of the family roles, the responsibilities that they're not able to do anymore due to limitations. And so validating this emotion, helping clients learn how to, of course, recognize and label these emotions is such a helpful early step. And exploring sort of beliefs and attitudes towards emotional distress, like unpleasant emotions are dangerous. They should be avoided. If I have strong feelings, I'm out of control. And using sort of self-validation of emotional experiences to kind of reduce the temperature and intensity of those emotions. So noticing and labeling them with an added component of self-compassion and being as non-judgmental as possible. So I'm feeling scared, I'm crying, and rather than sort of judging and saying what's wrong with me, this has been really hard. It makes sense that I'm scared. And I know that this feeling is temporary. Another really common feature is kind of this is avoidance that can manifest in a lot of different ways. And I think it's understandable that this is such a common feature, is understandable given the context of the illness and the pandemic itself. So behaviors that were adaptive in acute illness, like calling a doctor frequently, or early in the pandemic, like not taking public transportation, may become maladaptive in the long term. Patients, we've found, develop fears of internal states, so kind of like bodily states, and environmental stimuli, like going to the grocery store, that can lead to avoidance and escape behaviors, hypervigilance of body sensations, and excessive reassurance seeking that can impact well-being. So for instance, even like avoiding follow-up appointments in medical care because of fear of receiving bad news. I had worked with a patient who was mildly sick, went to the ER, very healthy, no health comorbidities, went to the ER, low oxygen, was placed on a ventilator for 6 weeks, had multi-organ failure when she was taken off the ventilator, and is now doing very well in her recovery. But she avoided doctor's appointments because she said, I thought this was going to be a 8-hour trip to the emergency room, and I wake up 2 months later with all of these health complications. So there's that sort of maybe a fear of engaging in medical care, or the opposite, that finding that it's comforting and doing a lot of checking and reassurance seeking. So what we've found to be helpful in our experience is identifying what the short-term benefits of avoidance are. What are those reinforcing factors? It relieves symptoms in the moment, but has a number of long-term consequences like social isolation and withdrawal, and can also perpetuate the anxiety and discomfort and fear. So working to sort of differentiate between false alarms and true alarms. So false alarms, just see. So we know that not all avoidance is unwarranted. The complicating factor with individuals who have had COVID is they may have a lot of residual physical symptoms. Some actions may be medically necessary. So differentiating what is medically necessary versus what is a false alarm, something that feels urgent psychologically and even in your body, but that is actually not something that you need to be avoiding. So the fear may be out of proportion to the threat. And the way to distinguish that is to have a really thorough understanding of a client's sort of medical needs, medical treatment, and trajectories to know what is safe and what may not be based on medical recommendations. And we've also found that, as I mentioned, avoidance doesn't always take the form of withdrawal from an activity, but can sometimes be excessive checking or hypervigilance of symptoms, which can maybe even be conceptualized as a form of avoidance where the fear of having a physical setback or medical decline is the emotion that's being avoided. So working with patients in situations where there's avoidance of activity, like going to the grocery store, progressive exposure to this feared stimulus, as well as, and the same with reassurance seeking, progressive exposure to doing less of those activities that align with reassurance seeking. And just to note that clients who meet diagnostic criteria for panic or specific phobia may benefit from a more sort of dedicated exposure protocol. This is more like this sort of general progressive exposure is, I think, probably most helpful for those with mild to moderate avoidance and acute stress response that impacts well-being, but doesn't rise to the level of a panic disorder. And of course, behavioral activation that is adjusted to meet the unique needs of individuals who have had COVID. So medical complications, ongoing physical symptoms can make it hard to carry out mood-enhancing activities. And so discussing this with patients, validating the bidirectional link between mood and activity, and acknowledging that some activities that they used to engage in before COVID may no longer be possible, at least in the exact way as before, due to various limitations. And that's not something that should be overlooked, but really kind of processed alongside thinking of alternative activities or modifications and defining those based on activities that tap into the same sense of meaning and purpose that the original activities did. So for instance, in this case, so let's say a patient said, I really enjoyed participating in my church congregation, and so exploring why that meant so much to them. Spirituality, teaching others, and social connection. The barriers that are impacting their ability to do it in the same way. Ongoing need for oxygen makes it difficult to travel and be there in person. So how can we still obtain and tap into the same values and pleasurable activities and pleasurable feelings by, for instance, participating in virtual church services, reading religious scriptures, and leading a virtual study group congregation. So I think it's really thinking about the adapting activities, acknowledging the loss of ability to engage in the same way, and adapting activities so that individuals can still lead a very meaningful, satisfying life, and thinking about what the elements of that satisfying life are specifically to them. And so with certain medical conditions like COVID, there's some data to suggest that, well, in other medical conditions, we already know this, and it's very likely in COVID, based off of preliminary work, that the infection or the prolonged impacts can make individuals a little bit more vulnerable to an overactive or sensitized stress response, particularly among those with severe infection. And this is something we observed often, is that people were having sort of the fight or flight, acute stress response, all those big symptoms often, and in a way that impacted day-to-day life. And another kind of COVID specific consideration is that the fight or flight symptoms can overlap with symptoms experienced in the acute phase of COVID infection, and therefore they could sort of have this overlapping reciprocal effect. So it may lead clients to assign meaning to these symptoms that occur when they're anxious and say, I'm having a heart attack, there's something wrong with me or my body. We hear that in a lot of different populations. It seems to be a really common experience among those with long haul. Individuals try and escape situations as soon as they begin to notice the symptoms. So just sort of talking about the fight or flight, how it developed evolutionarily, and what its purpose is, that it does help us in certain situations, can help sort of destigmatize these symptoms and make individuals realize that they're not just losing control. And so that their body is just acting as if they're in sort of a dangerous or threatening situation when that isn't really the case. And that may be due in part to the impact of COVID on the body and their experience early on. That's reminding them that really mirrors what the anxiety response is in the body. And so what we've introduced relaxation as kind of a series of helpful strategies to reduce the intensity of the acute stress response. And so things like 5-finger breathing, diaphragmatic breathing, but a consideration for individuals who have had COVID is that folks with ongoing respiratory difficulty or oxygen requirements may be a little bit reluctant to start with a breathing-based exercise. And so keeping that in mind, sometimes it's helpful to start with progressive muscle relaxation or imagery, and then maybe explore later on the utility and comfort with breathing-based exercises. And of course, distinguishing use of relaxation from avoidance, that relaxation should be used in situations where the distress is so high, other strategies are not could not feasibly be used. But we don't want to use relaxation in every situation in which people experience mild to moderate distress, because of course we want to show that people can tolerate and sit with that mild to moderate distress, and catastrophic things aren't going to happen. Mindfulness is a helpful piece, and in individuals with ongoing COVID-related illness, there's so much worry rooted in uncertainty about the future, about worsening symptoms, trajectory of symptoms, the pandemic itself, or preoccupation with physical functioning, that mindfulness has been such a critical tool to help people engage with the present moment, reduce judgment, and provide sort of relief from those future-oriented thoughts. And there's so much uncertainty. I think we've all experienced a lot of uncertainty in the last almost 3 years. And particularly among those experiencing long-haul COVID. COVID's new to everyone. And then the research in long COVID is in its nascency. People sort of doubt its veracity in various ways. And there's also, of course, a risk of reinfection. So uncertainty comes up a lot, as I'm sure others in this room have noticed. And exploring and validating those sources of uncertainty and the accompanying emotions it can bring can be really essential in helping people process it, talking about their specific fears. So taking it from a generalized, I don't know what's going to happen, to I'm afraid that my heart is going to go out because of what happened when I was in the hospital. And using ACT techniques to really facilitate acceptance of uncertainty, while also exploring the steps that individuals use to increase a sense of control. So in uncertain situations. So for instance, we know that a lot of people do this, I do this, is try to do things that increase my sense of control in a largely uncertain world. And sometimes it's adaptive and helpful, but if it's done too much or in certain ways, it can lead to restriction of engagement in activities, exacerbate distress, and in some cases be unfruitful because we can't guarantee certain outcomes. So accepting and acknowledging uncertainty, identifying adaptive actions that can help increase safety, while also kind of distinguishing those from unhelpful strategies individuals have been using to try to increase a sense of control, but really actually interferes with their well-being. And grief is something that seems to take a lot of forms and is experienced often by the individuals we've worked with in our clinic. So this may be an actual death or loss of a loved one due to COVID or during the pandemic, or someone who lost someone not due to COVID, but wasn't able to attend their funeral. Changes in functioning, mobility, fatigue, limiting activity, cognitive abilities, just independence and autonomy in general. Loss of social functioning, maybe limited by public health impacts or actions, or individual decisions to withdraw a little bit, and changes and loss in social roles and identity. So losing employment, losing certain relationships or ability to engage in activities like before. One of our patients was a dancer, and a really successful dancer, and due to post-COVID complications needed to have needed both below the knee amputations bilaterally. And that is such a profound loss of his sense of self and identity. And so there's so much variability in how the loss can present, and oftentimes they're overlapping. And so thinking about coping with loss, grieving those losses, sitting with them, and coming to a place to really integrating grief into their life, because I think grief never ends in some ways. It just evolves over time, and how to allow it to be a part of life while also emphasizing hope and building agency in the face of loss of autonomy. So in the latter, something we found helpful is really emphasizing persistent strengths and abilities that have not been lost. There's a vigilance of attention to the loss, of course there is. And so allowing sort of a balanced perspective to say this is absolutely a serious loss that we want to acknowledge and process. Let's also balance that with a recognition of strengths, of resilience, and how to leverage the personal qualities of each individual to kind of facilitate recovery and well-being. Oh, I'm seeing that it's almost 11. So a few other things that I wanted to mention, so increasing adherence, but if I had my last chance to talk about one other important thing today, it's sort of culturally responsive and care. So we know that the pandemic had a disproportionate impact on racial and ethnic minority communities, and really emphasized this existing structural inequities across systems, especially in healthcare. So I think this could certainly be its own talk, but thinking about culturally responsive care, using a multidimensional approach to assess cultural identity and the various aspects of that, race, age, generational influence, Indigenous heritage, religious affiliation. And also this came up a lot in a way that I think opened a lot of our eyes, was the discrimination people have faced in the medical system in the past, and how that impacts how much they want to engage, how comfortable they are, how much they trust the medical system. And so if someone had a really serious illness and they've sort of withdrawn and they're not comfortable getting follow-up care because of discriminatory experiences that they've had, or a loved one. So that I think has been really helpful in sort of exploring and understanding that, and seeing how we can maximize well-being and comfort within the medical system while also recognizing its flaws. And this is just a press release of our post-COVID cognitive deficit study that just wrapped up, and hopefully we'll be getting our publication out soon, sort of summarizing the effects, seeing if this is an effective non-pharmaceutical intervention to treat cognitive difficulties post-COVID. And I just want to thank my wonderful team at Weill Cornell and New York Presbyterian. We worked together across the board in all 4 of these programs, and it was a truly collaborative approach. And yeah, thank you so much. Please feel free to email me if you have any questions or thoughts or feedback. And I really appreciate being invited to speak today.
Okay, well, thank you so much. This is so packed with useful information, and so great to hear your state-of-the-art research, right, on, not just the quantitative, but also the qualitative and the subjective experience of all the people who are suffering with this. Very, very meaningful, and with the greatest appreciation for all you're doing. Now, I know that, we've reached the end, and so, and a lot of people need to jump off. But there are also a lot of questions in the Q&A. So I don't know, Dr. Oberlin, if you're able to stay for a little bit.
Sure, absolutely. Yeah, I would be really happy to.
Okay, so if there are people, Jen, you typically handle the chat box here. So
Yes. So Mary Beth Collins, you had a question. Can you unmute yourself? Do you want to ask it yourself? Or I can read it?
Yes, I'm happy to. Thanks again. I just thought the last hour has been so incredible. I just wanted a quick reiteration of those that you have found through all of this work to be the most vulnerable. We hear a lot about typically those with anxiety or depression tend to be the most vulnerable to develop long COVID. And I just wondered if there's any additional details in identification of those that are most vulnerable to develop long COVID.
Yeah, so it's a really good question. I think it's something that we're just starting to understand all of the various factors and predictors. So severity of illness, hospitalization certainly is a strong one. Also, individuals of racial and ethnic minorities are more likely to develop certain long COVID features, individuals with certain just sort of health comorbidities. So the data, it's so interesting, like the data suggests that there are trends such as that. There are demographic predictors, there are socioeconomic status predictors. And then in our clinics, there are so many exceptions to all of the models that I see someone who could not be is 20 times healthier than I am, has no comorbidities, is not in any of those demographic risk groups and still experiences substantial long COVID or even had severe illness in a really unpredictable way. So I would say right now, certain demographic factors, certain medical comorbidities and illness severity, as well as pre-existing mood symptoms. But even in our clinic, a lot of folks, this is the first time they've had clinical anxiety or depression. And it was told, they were like, what's going on? This is not me. I'm not used to this. And that was a really scary thing for people because it was so acute too. It's happened within a month. All of a sudden they feel totally different. So yeah, that's, the data is developing. Yeah, that's a really good question though.
Janet has her hand up.
Yeah, thank you, Jen. Dr. Oberlin, thank you so much. This is so fantastic. I could go on and on. I do want to highlight your most humane and respectful perspective. I have one quick comment and then one question. The question we could put on hold, but the comment is, we've been in conversation with various long COVID advocacy groups, the C19 Long Haulers Advocacy Project, Long COVID Alliance, which I would encourage all of you to look up. They're really phenomenal organizations. And one of the things that's been highlighted and that I think we all grapple with, and I think what you have addressed so thoughtfully, is the relationship between mind, body, and the risk of medical gaslighting and the dangers of medical gaslighting. And you have so beautifully addressed that. You have really beautifully addressed that. So a question that I have related to that is in terms of addressing the psychological piece and the psychosocial piece of it. The relationship, and this goes back to Alalanda's work on attachment patterns in pain, general pain issues. And is there any data on relational attachment patterns, relational trauma, and the fluctuations of long COVID symptoms? Again, mindful of the risk of medical gaslighting, but how attachment patterns can impact those fluctuations. And thank you, Dr. Oberlin, and welcome to everyone.
Thank you for all the good work you're doing with all of these organizations, and everyone in this room. I know has contributed to helping this population, working with this population as much as possible. And I really appreciate everyone's efforts. So, and I thank you for summarizing that. That was very gracious of you. I do not know the answer to that question. The research on attachment patterns in these presentations, it's so thoughtful, so relevant, and I am not sure. But if anyone wants to do that, I think it would be a meaningful contribution to the literature. And if anyone else wants to jump in and knows a little bit more than I do, which isn't very much, please feel free.
Thank you, Dr. Oberlin.
We have a question from Ariana Jaffe. Is she here, Ariana? Do you want to ask it or I'll read it? Just unmute yourself if you do. Okay, I'll read it. Is there data differentiating individuals who were vaccinated prior to infection?
Yeah, so the individuals who are vaccinated prior to infection have a lower risk of long COVID in general. And among those that do experience long COVID, the intensity of the symptoms are less in magnitude. So yeah, so it does reduce risk in a meaningful way. Mhm.
We have a question from Miguel Roberts. I don't know if you're here, Miguel. You can unmute and ask your question, or I'll read it.
I'm here. Can you hear me?
Yes.
Yes.
Okay, perfect. Yeah, I had two questions. So sorry to kind of go for the twofer, but one was about differential impacts of long COVID on children. I didn't know if the data that you presented, Dr. Oberlin, also applied to children. And so if you could talk about that. And also you touched on some of the differences with specific populations in COVID across like racial and kind of low SES. So I was wondering if you could talk about that for a minute. Specifically, I was looking for evidence of differential impacts by race and SES on long COVID. Thank you. And thanks for your presentation.
Thank you. These are two great questions. Everything I described today applies to long COVID in adults. So I'm not, and the extent to which this can be applied to children, I'm not sure. So most of my background and work in clinically and in research is in adults. I do know there is a growing literature on how this can manifest in children, and I'm sure there's some variability in the mechanisms, given protracted neurodevelopment in child and adolescents, things like that. But all of this today applies to adults. And so in terms of kind of differential impacts of long COVID on racial and ethnic minorities and low SES, the data is mostly from these large population-based cohorts who get demographics and then look at risk for long haul. And one thing about these studies is that we recently had a definition of long haul come out in 21. So the ways it was defined across studies has varied for some time, and the measures that are used to identify long haul and does the symptom fit, even with cognitive, are people using a MoCA cutoff? Are they doing more comprehensive assessments? So that has really varied. And so there is some variability across the literature. Some suggest there aren't differential impacts, but the majority of studies suggest that individuals from kind of disadvantaged backgrounds are at higher risk for long COVID. It could also be that and the reasons for that are not sort of entirely understood yet. One thing that comes to mind for me is a hesitancy to get medical care, an understandable concern given discrimination in the healthcare system. But I'm sure that there are multiple factors. I'm not sure if that answers your question.
Yes, that's very helpful. Thank you.
Okay, the next question is another one from Ariana Jaffe. I'll just read it. How do you square reducing hypervigilance with recommendations from physicians treating long COVID that patients should track their symptoms?
Yeah, so this is a really good question and very important distinction, because we worked a lot with individuals of severe illness who were hospitalized in the ICU, often on ventilators. So this was a really high risk group that came, out with a lot of medical vulnerabilities. And so this is when collaboration of care became essential for us, was talking with the interdisciplinary team, talking with their pulmonologists, intensive care physicians, and rehab providers to say, let's get as specific as possible. We had some patients who were checking their pulse ox 20 times a day when the physician was recommending 2. So if you say that, they said, well, my physician recommended I check it, is the intensity. What is the intensity? What is the frequency? Is it coming from is it beyond what's been medically recommended? So getting as detailed as possible into medical recommendations. So if someone is said, you really can't do high intensity aerobic activity, we don't want you running a marathon, but you can go for brisk walks. So some individuals were afraid to kind of feel their heart rate change in any way. And we know that that's helpful. At least some level of aerobic activity is important for recovery. So it's getting as much information as possible. Say, what is the medical necessity here? We need to acknowledge that and make sure you're safe. And what is beyond, out of proportion to the medical recommendations that's impacting your quality of life?
Okay. Now I'm going to mispronounce your name, but I believe it's Chong Sang.
Hi. Yeah, no worries. Thank you. I'm on speakerphone because I'm driving in Jersey, but my name is Bill Sang. I work at NYU Langone in Rusk, and I work with a lot of COVID patients. My question is in regards to, I guess, motivational interviewing. I've had several patients who maybe used to be really good runners, and they have kind of gotten back into exercise, but they just have a bit of an avoidance issue regarding things like running specifically, or jogging, or things like that. And I wonder how you might recommend, addressing that aspect. Thank you.
Yeah. So it's a great question, because people, that's a big part of people's identities and it's so physical activity is so important for mood and cognitive well-being, and recovery. And so getting people back to doing what they were doing is essential, like you said. And if they've been medically cleared, I'm assuming that those are the folks that you're asking about, that their doctors say it's safe for them to do it. And they may be hesitant to initiate it due to a fear of re-experiencing certain symptoms. So with COVID, in acute phase, shortness of breath is a big one. That's something in acute illness people often experience. And we also experience that when we exercise. So kind of there can be this association that's developed where people feel fearful when they experience shortness of breath, even if it's totally normative. So talking about what makes the kind of having the fears behind it, what the thoughts are, what the concerns are, and if they try, what happens, what symptoms, how does their body feel, and what thoughts are going through their head. So that's one aspect of it. The other is kind of understanding those and targeting those. And in cases where patients say, I'm not afraid, I don't know why I don't want to do this, I have no concerns, I'm not afraid for my body, I know I'll be safe, is the motivational interviewing stuff that you mentioned. So talking about why exercise was meaningful to them in the past, what they got from it, how it impacted their daily life and their well-being, and assessing both their motivation and using MI strategies to increase motivation, as well as sense of self-efficacy. Because I think that's also, people can be very motivated to do something, but have low self-efficacy. Say, I haven't exercised in 6 months, I don't think I can get back to it, I feel too overwhelmed. So that sort of multiple sides that can impact engagement, the motivation piece and the self-efficacy piece. I think the way that I get myself to exercise is I use the 5-minute rule, which I get dressed and I say, I can do anything for 5 minutes. I'm going to just do this for 5 minutes. And after 5 minutes, I can stop, and that I will know that I accomplished what I set out to do. But once I'm dressed and I get started, I don't want to stop. But it's a nice, I think that, I think that can be a helpful way to sort of initiate activity and make it feel more manageable, because, you can stop after 5 minutes.
We have a question from Sally Riggs.
Hi, sorry. Can I just jump in and say something a little bit about exercise? As someone who has long COVID and has lived with it for 3 years and is also an athlete, I used to be an ultramarathoner. There are just some misnomers around long COVID and exercise, and I just wanted to clarify a little bit. Long COVID is an organic illness, primarily characterized by lack of energy at a cellular level. And post-exertion malaise is real. And if you have long COVID and you exercise, you will get worse. I know because I did it. I am a runner, and most people who are runners want to run and don't have motivation problems. And I tried to run and it got worse and worse and worse. And ultimately I had to stop running for a very long time. And I've now started very slowly building back up again in a very careful and calculated way. So if you have patients who are telling you they want to exercise, the key question you have to ask them is, how do you feel 48 hours later? And this is not delayed onset muscle soreness. This is, I can't get out of bed, because most of us who are athletes are used to feeling sore the next day, but we're not correlating, I felt like crap and I couldn't get out of bed for a week, with that run that I tried 2 days ago. And if you keep exercising in any way at all, like I was crashing from yoga that was totally supine and basically just stretching. And then I'd be like for a month, barely able to function. So please, if you have patients who are not sure if they have long COVID or in that 3-month recovery from acute infection and have, and are athletes and are trying to exercise, please tell them to hold back, because 3 months of gentle training and maybe missing the occasional race, but not getting long COVID and losing your life for 3 years is way better than the other way around. And the person who has patients who have motivation problems, I mean, that for me would be a differential of long COVID. Like someone who has long COVID is trying to exercise and then is crawling across the floor for the next 2 days. So if you have patients who don't have the motivation to exercise, something is happening there, right? And it could be that they're experiencing acute chest pain, shortness of breath, which is all of what I was experiencing, and trying to push on through like all athletes do. Do not let your patients do that. The push on through is the worst thing in the world ever.
Yeah, I really appreciate your feedback and also you sharing your experience. And I'm sorry that of everything that you've endured, and then especially that loss of ability to do what you loved so much at the intensity that you did before. And it's such a good point. I prepared a talk that was about 2 hours long, and it was only about able to get to half today, but I did have a section on exactly what you were mentioning. Fatigue. This is a real physical symptom at a cellular level. And what you are referencing is also this overexertion, and that the delayed impacts of overexertion, and that those are real, and that we really, and sort of thinking about how to personalize recommendations as much as possible, and small bites of changes, and seeing, okay, walking. So one patient I worked with, she was having substantial fatigue and PEM that you mentioned. And so we started with her walking. She, New York, we all live in apartments, walking, just going to elevator, walking down, getting her mail in her building, walking back up. And that was the most kind of activity that she did. And then monitoring, a lot of self-monitoring, seeing how she felt later that day and the next day, and then saying, okay, what about the pharmacy across the street? And so I with PEM in particular, is being like you said, is being so considerate, not making assumptions about what people can do. And knowing that it's really individualized. So it's a really good point. I appreciate you bringing it up. Thank you.
Any other questions? Do you any hands raised? I see Ibrahim.
Yes, I just interested in the program you developed, or the university developed, to work on the executive function. Mm-hmm. And what is the initial results? What is the components and the initial results?
So yeah, thank you for asking. It's a study we're very excited about. So it's a cognitive intervention. It's delivered on an iPad via an app on an iPad, and it involves cognitive exercises that specifically target attention and sort of cognitive control. So it was developed by cognitive neuroscientists, and then they worked with researchers, coders, programmers to gamify it. They said, we have this neuroscience-based intervention. Let's make it engaging for people. No one's going to play it if it's boring. So there's levels and features, but it really is meant to repeatedly and consecutively target certain cognitive processes. And so the original data was like the first few studies were done in individuals with ADHD. This treatment is actually FDA approved. It just got FDA approval last year for the treatment of ADHD because it is successful in targeting issues with sustained attention and cognitive control. So those data in a very different population are compelling, and we're seeing if this generalizes to people who have had COVID because the cognitive profile can overlap to some extent. So our participants play 30 minutes a day, 5 days a week for 4 to 6 weeks. They can play it on the bus. They can play it on their lunch break. It's easy, very accessible, and people tend to enjoy it for the most part. So we're keeping our fingers crossed that it is effective and we have good results. But yeah.
Will it be available to refer the patient for?
So it's actually available. So it's available on iPhones currently, but it needs to be prescribed by a physician. It's like, I've never known this prescription process before because I'm just used to prescription processes for medication. So physicians would prescribe it, and with the prescription, individuals are given a little code so they can access the intervention. So right now it can be prescribed. People can download it on their phone very quickly. It's prescribed for ADHD. So for any non-ADHD conditions, it would just be off-label, but it's very low risk in terms of side effects. It's not like a medication that has substantial physical side effect risk because it's sort of.
If the doctors are aware of this.
So probably not. I would be surprised. It's pretty new. It just got FDA approval 6 months ago. I think, when we talk about it with our sort of physician colleagues, that prescribing a digital intervention or an app is sort of a new experience for them. So I have an email that I send if people are interested that includes instructions for physicians on how to prescribe it if they'd like.
Thank you. Thank you. I appreciate your presentation. Very helpful. Thank you.
Thank you.
See, Ruth Jaffe. Oh, got to unmute. Ruth, can you unmute?
Okay. I had started to say that I've been fascinated by your talk. It was incredibly informative, educational, and opened up our minds to a lot of the issues that we've been tackling and trying to understand. And I was interested in how you connect this apparently general phenomenon of brain fog from the neuroscientific point of view. If you draw a line to what you've just been talking about in relation to cognitive intervention, in the old days, we used to try to tease attention from a further process, so to speak, to sort of pull apart the perceptual aspect from the more, quote, higher order cognitive aspect of an understanding of a situation. How do you do that with the populations that you're dealing with?
Yeah, so I think what makes that hard too is that a lot of the studies where we're getting these great incidence rates, prevalence rates are doing a MoCA. So that's just like a general assessment of, like a global screening measure and saying, does someone reach this threshold or not? And they don't, because there's such huge studies, can't collect really comprehensive neuropsych data to look at the specificity of this. So to delineate between basic attention and sustained attention and set shifting and these sort of things. So in our trial, for instance, that we just finished up that we're now analyzing, we did a really long cognitive battery. like an hour and a half of different neuropsych tasks. And we often split it up for people because it can be cognitively fatiguing for them to do so much of this. And so we have, really to the extent possible, are trying to distinguish between the elements of attention that may be most impacted, because of course that corresponds, there's these like brain behavior relationships. So that also helps us to isolate what areas of the brain might be more impacted based off of the cognitive profiles and getting into the depths of it. But I think it's really, I think we're just at the start of understanding the profile and the range of the profile.
Thank you. Thank you.
One last question, anybody? Okay, Patricia, do you want to unmute?
First of all, thank you so much. You're just phenomenal, and I really hope we can have you back. And Dr. Riggs, who spoke, is presenting in another couple of weeks, and we will invite you to that. And what we're hoping to do is to really create a dialogue around this very important issue of what long COVID is and what we should be doing, what we could be doing. And so thank you so much. And I'm fascinated on many levels about this app. And I wonder if you have information about the app, because some of us also work with people with ADHD. And I'm thinking it would be interesting to look at this and see if this could be something that we can then try to find a prescriber to prescribe. So
I'm going to type in the chat. This is the name of the company that sort of so it's an industry, I don't know how to, so it's an industry group who work with researchers to develop it. And then they kind of do all the like access stuff. So it's called Achille Interactive. Whoops, let me send it to the whole group. I think I just sent, and on their website, they have a ton of information. So they have the data regarding the FDA approval, data regarding the prescription process, existing studies, studies that are in progress like ours.
Okay, thank you. Wonderful. Thank you. I think Maureen had to leave or is about to leave. And does anyone else have any other questions? Knowing that we can have Dr. Oberlin back at some point, so we don't have to jam everything in just now.
Can we get copy of the presentation?
Sure.
Okay. We will be able to send a link to the recording to the clinicians on the call.
Okay, thank you.
Yeah. And we again invite everyone to sign up for additional presentations we'll be having as we build on our knowledge. I mean, one of the things we did say that we started looking at this in October of 2021, and how far we've gotten in such a long period of time, or short period of time. And we have several more speakers lined up to talk about different aspects of long COVID. And again, this work is being generated by this group, and we invite you to join this group and help us generate and ask the questions and find the resources. So you are all invited to join and attend at whatever regular or irregular way you can. So Janet, do you have a question or comment, or your hand is up? Or...
Just a very quick comment. I have been saying so much these days how good healthcare practice, no matter what discipline, embodies both scientific expertise and compassion and humanity. And Dr. Oberlin, clearly you embrace that. And I just wanted to thank you so much for that. I mean, really, thank you. Thank you.
That made my week. I really appreciate that. That was very kind. Thank you all for having me. It was such a pleasure. I really appreciate the opportunity.
Well, thank you. Thank you. This is work of the heart as well as the mind. So thank you. So is any other questions or comments before we close? Or we've only gone a half hour over. That's pretty good. Well, thank you all. And we look forward to seeing you at another meeting or another presentation. Take care.
Thank you
Bye-bye.
very much.
Thank you, Lauren.